is there.
Yeah, I have actually, madam, I have already circulated the message to SMS Jaipur, then AIMS Mangalagiri, AIMS Raipur, AIMS Bhubaneswar.
Ma'am,
Yeah,
you can
thank
start,
you.
ma'am. It's live.
Yeah, and
Yeah.
Jipmar, of course,
Ito
because
full
Professor.
screen kora. Good evening.
Yeah, and
Good evening, everyone.
I have already circulated to Calcutta Medical College, National Medical College, Kolkata.
Mute কৰি দিবা নেকি সবকে?
অতি ধ্যান পায় ভাই হৈছে নি আগৰ
Good evening, everyone.
Good evening, madam. We can start.
Good
We can
evening.
start
Yeah,
now.
we can start. Today, our fourth class, fourth Nebaoi Classroom. So the topic of today's classroom is pathophysiology and complication of chronic suppurative otitis media, tubotympanic variety with management. Speaker will be Anjay Kumar Pal. And now Dr. Shubhamoy Chakraborty will introduce our guest, Dr. Shivaraman Ji, Professor Jipmer.
Yeah,
Dr.
thank you, madam.
Shubhamoy.
Thank you, madam. And welcome to all Nebaoi members and the other members, those who are present today in this fourth webinar. So it is my privilege to introduce Professor Shivaraman Ganeshan, currently serving as a professor, Department of ENT, JIPMER. He completed his MBBS in JIPMER, MS in ENT from JIPMER itself, and DNV with Advanced Fellowship Training in Head and Neck Surgery from RCC Trivandrum, and has further strengthened his academic leadership through FAMER Fellowship and International Robotic Surgical Training. Clinically, Dr. Professor Shivaraman's expertise spans cochlear implant surgery, skull-base surgery, and head and neck oncology, combining surgical precision with a strong focus on functional and quality of life outcomes. His research portfolio is equally impressive with over 70 peer-reviewed publications, many in high-impact journals, and significant contribution to areas such as head and neck cancer outcomes, cochlear implant, mucormycosis, and quality of life research. He has been a principal and co-investigator of multiple ICMR-funded projects, including innovative work on digital solutions for speech therapy in cochlear implant children and studies addressing unmet rehabilitative needs in ENT patients. So with this, I welcome Professor Shivaraman Ganeshan, Professor Head of the Department of ENT, JIPMER, as an expert for today's webinar. Thank you. Welcome you, sir.
Thank you.
Thank you, sir. Thanks for the kind words.
Thank you, Dr. Shubhamoy.
Thank you,
Dr.
ma'am.
Anjan, Secretary Nebaoi, can you please introduce our speaker?
Thank you, ma'am. Thank you. So today's speaker is Dr. Ajay Kumar Paul.
Anjay.
He is a third-year student from Tezpur Medical College. He is one of the brilliant students from that college. So today's his discussion will be on pathophysiology and complications of the tubotympanic variety of chronic suppurative otitis media. So that is the disease what we found in our clinical practice most commonly, though the complications are not that common nowadays, but that is one of the most frequent entities of the disease that we encounter in our day-to-day practice. So this discussion is going to be very interesting, and I hope the interaction will be a very fruitful one. And there is a lot of things, new things to be discussed in this, mostly in the complication part and the pathophysiology and all. So I welcome Dr. Ajay Kumar Paul for his
Anjay.
lecture.
Anjay, Dr. Anjan. Anjay Kumar.
Ajay Kumar Paul. Anjay Kumar Paul.
Thank you, Dr. Anjan. So our moderators are Dr. Rupam Buragohai and Dr. Abhinava Ghosh. Dr. Rupam Buragohai, he is a professor, head of the Department of ENT in Tezpur Medical College. I think he is not there. He is a bit busy. Dr. Manas Pratim, are you there? Dr. Abhinava Ghosh?
Yes, ma'am, I'm here.
You are there, no? Abhinava is a ENT,
Yes.
prominent ENT practitioner. Is basically his interest in ear. He is established in Guwahati, so he will be moderating. And Dr. Hiranya ma'am is not there. Hiranya Bora, our chairman, scientific committee. She is little busy. So now we can start the lecture. Dr. Anjay, I think you can start it.
Yes, thank you, ma'am. Good evening, teachers. I am Dr. Anjay Kumar Paul, third year PGT, Department of ENT, Teshpur Medical College and Hospital. Dr. Rupam Borgohain sir is our HOD. I am going to discuss the pathophysiology, complications, and management of tubotympanic type of CSOM. So we will discuss under these
Please
following
mute
headings.
everyone.
We will first get an
Rohan,
introduction to the topic, and then the pathophysiology, clinical
mute.
features, and finally we'll reach the surgical treatment and the complications of CSOM. So coming to the introduction, the definition of CSOM is chronic otitis media, or COM as it is better termed today, is an inflammatory process in the middle ear space that results in long-term or more often permanent changes in the tympanic membrane, including atelectasis, dimer formation, perforation, tympanosclerosis, retraction pocket development, or development of the cholesteatoma. Now, CSOM has been classically classified as mucosal chronic suppurative otitis media, which may be in an inactive stage or an active stage, and then the squamosal CSOM, which may again be an inactive stage or an active stage, and a healed CSOM. Also, there is a Nadol classification, which classifies CSOM with chronic otitis media in an inactive stage, that is further classified as with cholesteatoma or without cholesteatoma. Then chronic otitis media in an inactive stage, which is further classified with perforation, then with tympanosclerosis or permanent retraction pocket development, then with ossicular disruption or resorption, and with adhesion or atelectatic otitis media. Then it is also further classified as otitis, inactive chronic otitis media with frequent reactivation. That was the Nadol classification. Now, mucosal CSOM is also known as tubotympanic disease, while squamosal is also known as aticoantral disease. Coming to the tubotympanic type, it is a pyogenic infection and inflammation of the mucosa of middle ear cleft, which includes the eustachian tube, the middle ear cavity or the tympanum, then the adytus, the mastoid antrum, and all the mastoid air cell system. And it is an infection lasting for more than 3 months, which is characterized by persistent perforation of the pars tensa of tympanic membrane, also called a central perforation, then persistent ear discharge or recurrent ear discharge, decreased hearing. Now, this is a picture which depicts the middle ear cleft, which includes the eustachian tube, the middle ear cavity or the tympanum, and the adytus to the mastoid antrum, and the associated mastoid air cells. So the tubotympanic disease is mostly it involves the eustachian tube and the mucosa of the middle ear cleft, while the aticoantral disease will infect the bone also. There will be osteitis and inflammation and resorption of bone. So that is why aticoantral disease is termed as dangerous or unsafe type, as it is associated with more intracranial complications as compared to tubotympanic variety. Now, coming to the pathophysiology, what are the predisposing factors for tubotympanic disease? It is mainly recurrent upper respiratory tract infections like acute and chronic sinusitis or adenoiditis in children, or it may be tonsillitis, recurrent bouts of tonsillitis, then upper respiratory tract allergy like allergic rhinosinusitis or allergic rhinoconjunctivitis, leading to ascending infection through the eustachian tube. Then pre-existing otitis media with effusion, which was inadvertently treated and which did not resolve, that may result in development of tubotympanic disease. Then congenital anomalies like cleft palate, immunodeficiency states, and poor socioeconomic status are the predisposing factors. Now, what is the bacteriology of the disease? The most commonly isolated organisms being Pseudomonas aeruginosa, Staphylococcus aureus, Proteus species, Klebsiella, bacteroids, and Streptococcus. There are also E. coli. There is also E. coli associated with the disease. What are the routes of infection? Now, from where these bacteria reach the middle ear cleft, it is via the, most commonly it is via the eustachian tube, that is following an upper respiratory tract infection or forceful nose blowing or regurgitation of milk in case of infants when they are breastfed with their head lying supine as compared to the rest of the body. Then infections may reach via the tympanic membrane perforation following an acute attack of ASOM or post-traumatic, that is traumatic perforation leading to the development of tubotympanic disease or chronic suppurative otitis media. Then hematogenous is a rare route of infection which generally involves after exanthematous fever like measles. Now, what is the pathology of this disease? As there is ascending infection or allergy via the eustachian tube to the mucosa of the middle ear, there is recruitment of the immune system. There is antigen presentation by the bacterial or viral capsular antigens, which are processed by the recruited immune cells, and there is recruitment of others immune other parts of the immune system, like the activation of complement system, then secretions of cytokines like tumor necrosis factor alpha, interferon gamma, then secretion of interleukins like interleukin 1b, interleukin 6, interleukin 8. Then also there are pro-inflammatory regulators which are released along with the pro inflammatory mediators like interleukin 2, interleukin 10. They will keep the inflammation in check so that there is no damage to the self tissue. However, due to inappropriate treatment by empirical use of antibiotics and not using the antibiotics as per the culture sensitivity, due to inadvertent or incomplete treatment, there is a development of residual infection in the middle ear, which further reactivates with recurrent bouts of upper respiratory tract infection, and it follows the same inflammatory process ensues once again. So after this repeated bouts of inflammation, there is development of granulation tissue in the middle ear as a response to the ongoing recurrent inflammation. There is also fibrosis, sclerosis, which may lead to tympanosclerosis or myringosclerosis. There is deposition of chalky white calcium in the around the ossicles, leading to ossicular stiffness, or in the tympanic membrane, leading to its decreased compliance. Now, these are the pathological changes which are observed in the tubotympanic variety. That is, the tympanic membrane will present a central perforation and there will be myringosclerosis. There may be ossicular destruction, there may be tympanosclerosis, fibrosis, and adhesions of the tympanic membrane to the middle ear, medial wall of the structures present in the middle wall of the middle ear. Then the middle ear mucosa will appear pale and pink in inactive stage of the disease when there is no active inflammation. However, it will be edematous and congested in active stage, and the mastoid will be sclerosed. Now, coming to the clinical features, there will be intermittent profuse mucoid to mucopurulent ear discharge, and which is generally odorless and usually not blood-stained. Hearing loss, it is usually conductive in type, and it is 25 to 60 decibels, but might be normal in small or dry perforations. And there is round window shielding by ear discharge, leading to better hearing during the acute attacks of ASOM in a long-standing case of COM. Now, in the tympanic membrane, there will be perforation of the pars tensa. Coming to the perforations, it may be small in size when it involves only one quadrant or less than 25% of the total surface area of the pars tensa. It is a medium one when it involves two quadrants or more than less than more than 25 and less than 50% of pars tensa. It is a large one when it involves three or more quadrants and with a white tympanic membrane remnant or greater than 50% of the pars tensa but less than 75%. When it involves more than 75% of the pars tensa and only a thin rim of the annulus remains, it is called as a subtotal perforation. And when this rim of annulus is also destroyed, it results in a total perforation of the pars tensa. Now, this is a picture showing large central perforation with a congested and edematous middle ear mucosa, suggesting that there is ongoing active inflammatory process. It is in an active stage. This is a picture of development of an oral polyp, which develops as a result of repeated bouts of inflammation of the middle ear. Following that, there is development of granulation tissue and oral polyps, and this picture suggests a red fleshy polyp suggestive of unsafe type of disease or an aticoantral disease. Now, coming to the stages of tubotympanic disease, it is in active stage when there is presently at the time of examination, the patient presents with otorrhea, there is tympanic membrane perforation. It is in a quiescent stage when otorrhea is absent. Tympanic membrane perforation is present, that is, it is a dry perforation, and the last episode of ear discharge was less than 6 months. It is in an inactive stage when there is no otorrhea at presentation, and there is a residual tympanic membrane dry perforation, and the last episode of ear discharge had been more than 6 months ago. And it is a healed one when there is absence of otorrhea and there is no tympanic perforation. That means the perforation has healed and there is formation of a dimeric tympanic membrane. Now, coming to the investigations, apart from the routine blood pathological and biochemical investigations and otoscopy, we will go for examination under microscope for confirmation of our otoscopic findings. That is the site of the perforation, size of the perforation, then the epithelial migration at perforation margins, whether there are adhesions or tympanosclerosis, the assessment of the auricular chain integrity, the collection of discharge from the middle ear for culture and sensitivity test, and to check the presence or absence of granulations and unhealthy granulations and cholesteatoma. Now, ear discharge swab, which has to be sent for culture and sensitivity. Then, apart from tuning fork tests, we will go for pure tone audiometry to record the presence of hearing loss, the type of hearing loss, the degree of hearing loss, then the status of hearing of the other ear, and it will be used as a record to compare the hearing post-operatively if we go for surgical intervention in the patient, and also for medical legal purposes. Then we go for X-ray mastoids, that is bilateral 30-degree lateral oblique sculler's view, when there is indication of cortical mastoidectomy in cases which are not responding to conservative antibiotic treatment. And we will also go for high resolution CT scan of the temporal bones. Coming to the treatment of tubotympanic disease, beginning with the non-surgical treatment, we should first ask the patient to take precautions, as prevention is always better than cure. So what precautions we will ask in case of infants, breastfeeding infants, we will encourage the parents to lift the child's head above or while breastfeeding, and to avoid bottle feeding on supine position. Then avoid forceful nose blowing in adolescents or children. Then in cases of sports person like swimmers, divers, athletes, so we will ask them to plug the EAC, external auditory canal, with Vaseline smeared cotton plug so that water does not enter the ear canal. Then we should ask the patients to avoid putting oil, water, or any other self-cleaning objects. We will go for oral toileting, and it is indicated for active stage. We will go for dry mopping with cotton swab. However, suction clearance is the best method. Wet mopping may be done with 1.5% trichloroacetic acid solution, and it removes accumulated debris and the acidic pH. It discourages the bacterial growth. We will use antibiotics, like topical antibiotics may be used in the form of eardrops. Then antibiotics and steroid combination eardrops may be used for granulations and polyps. Then oral antibiotics will be used for severe diseases. And we will go for antihistaminics and nasal decongestants administration to the patients, which may be systemic or topical. Then we will treat the focus of respiratory infection or allergy, which is the beginning of the disease or the pathogenesis of the disease, like elimination of any infective foci in the tonsils or pharynx or the nose and paranasal sinuses. then treatment of chronic eustachian tube dysfunctions and middle ear effusions with grommet insertion, then treatment of any allergic diseases of the nose and upper respiratory tract. Coming to the surgical treatment, surgeries indicated in the inactive or quiescent stage are the myringoplasty and tympanoplasty. However, in the active stage, surgeries indicated are cortical mastectomy or oral polypectomy in cases of oral polyps. Now, what are the methods to close tympanic membrane dry perforations? If the perforation is less than 2 millimeter, we will go for chemical cauterization with silver nitrate and trichloroacetic acid. We may go for fat plug grafting. We may go for paper patching with cigarette paper after refreshing the margins with 1% phenol. And if these measures fail, we have to go for myringoplasty, which is also indicated in greater than 2 millimeter perforations. And we can go for tympanic membrane patches like cartouche TM patches. Now, this is a picture showing the chemical cauterization of small dry perforation in case of safe type of disease or tubotympanic disease. Now, what are the surgical approaches to the middle ear? First is the post-auricular approach using the Wildey's post-auricular incision. Then we can go for Lampert's endoral incision using the endoral approach. Then we can go for Rosen's permeatal incision in cases of transcanal approach to the middle ear. We're coming to the hearing restoration. What are the principles and aims in which what are the principles and aims of hearing restoration, following which we will plan any operative intervention in the patient? After the surgery, we should get a intact tympanic membrane. The ossicular chain should be intact. There should be a functioning receiving and relieving windows. Then there should be acoustic separation of these windows. That is, sound waves should not hit these windows at the same time. There should be a functioning eustachian tube, and all the eustachian tube dysfunction has been eliminated. There is absence of sensory neural hearing loss, and there is any active foci of there is no any active foci of infection or allergy in the middle ear cleft. Now, what are the methods of hearing restoration? First is myringoplasty, which is surgical closure of perforation of pars tensa of the middle ear without ossicular retraction. What are its aims and indications? To permanently stop ear discharge, that is to make the ear dry and a safe one. To improve hearing if the ossicular status integrity is maintained and mobile, and there is an absence of sensorineural hearing loss. Then prevention of ongoing complications like further hearing loss or tympano or myringosclerosis or adhesions or mucosal bands and vertigo. Then for wearing of hearing aids to get an intact tympanic membrane in occupational patients, cases like military people and pilots, in swimmers and divers who want to continue their recreational activities. Now, what are the contraindications of myringoplasty? There should not be any purulent ear discharge, that is, the ear has to be dry. There should not be any otitis externa or any respiratory allergy foci, age less than 7 years, as the eustachian tube is not fully developed, if it is the only hearing ear, and if there is presence of cholesteatoma. What are the techniques of myringoplasty? Underlay technique, where the graft is placed medial to the annulus, fibrous annulus, and the handle of malleus. Overlay in technique, in which the graft is placed lateral to the fibrous annulus and the handle of malleus. And the grafts used is the most commonly used is the temporalis fascia. And second most commonly used is the tragal or conchal cartilage or tragal perichondrium can also be used. Vein graft, fascia lata, and dura mater are other grafts used for myringoplasty. Now, this is a picture showing the overlay and the underlay technique of graft placement in myringoplasty. Coming to the tympanoplasty, that is the second method of hearing restoration, that is surgical removal of disease with reconstruction of hearing mechanism without the mastoid surgery, and it is classified from types 1 to 6. Now, this is the picture showing the types of tympanoplasty in which the type 1, the graft is placed over the handle of malleus. Then in the type 2, it is placed over the long process of incus, and in the type 3, it is placed over the stapes head. In type 4, it is placed over the foot plate of the stapes. In the type 5, when the stapes foot plate is fixed, we create a second window or a fenestration in the semicircular lateral semicircular canal. And in type 6, we do a sono inversion where the receiving window is the round window and the relieving window is the oval window. Coming to the third method of hearing restoration is ossiculoplasty, that is surgical reconstruction of the ossicular chain. The ossicular graft materials which are used are the autograft, that is harvested from the patient himself from the operating ear, that is the ossicles, like incus and malleus. Cartilage can be harvested from the tragus or the Simbaconcha. Bone may be harvested from the spine of Henle or the mastoid process. Homograft includes ossicles, cartilage, and bone, and biomaterials available as partial ossicular reconstruction prostheses or total ossicular reconstruction prostheses, which may be made of polyethylene, or more commonly used are the Teflon ones, or rarely gold. Now, coming to the complications of tubotympanic type of chronic otitis media. The first complication is the hearing loss, which the patients commonly complain of. It is conductive type due to loss of permanent, it is a conductive hearing loss due to a permanent perforation of the pars tensa, and there may be damage to the ossicular chain as well. The other complaint which the patients also worry of are the persistent otorrhea or intermittent recurrent otorrhea, which is a continuate mucoid or mucopurulent, and it often flares up with after a upper respiratory tract infection. Then the third complication, there may be development of acute mastoiditis or inflammation of the mastoid ear cells, the mastoid antrum, and which may lead to development of subperiosteal abscess in the postauricular region and the sequelae of those abscesses. Then there may be development of tympanosclerosis leading to stiffness of the ossicular chain. There may be development of myringosclerosis, granulation tissue in the middle ear, or polyps coming out of the perforation into the external auditory canal. There may be hardening or scarring of tissues in the middle ear. Then there may be labyrinthitis, that is inflammation of the inner ear caused due to the toxins, bacterial toxins, which reach the inner ear, and immune system mediated cytokines leading to vertigo and sensorineural hearing loss. There may be facial nerve palsy when the fallopian canal is involved, leading to weakness or paralysis of the facial muscles on the affected site, and it occurs in rare instances in tubotympanic type of disease. There may be other rare intracranial complications which are more common in aticoantral disease than in tubotympanic variety, which include extradural, subdural abscesses, temporal lobe or cerebellar abscesses, meningitis, otitic hydrocephalus, lateral sinus thrombosis, and others. So that's all for today's discussion. Thank you. Thank you.
Thank you, Dr. Anjay. May I request Dr. Shiv Raman, please give your comments. Dr. Shivaraman, please.
Yes. So it's a well presented by Dr. Ranjoy. I'm happy that I'm happy and glad that he is presenting on mature. So I'm happy and glad that he's presenting very boldly in front of a big audience like this. It's a great opportunity for him also. But I would like to ask him some few questions before I would give some suggestions. May I know the role of eustachian tube dysfunction in these scenarios?
Yes, sir. Eustachian tube plays a major role in tubotympanic variety, as it is associated with the ventilation of the middle ear, the tympanum. So eustachian tube dysfunction develops due to the ascending infection or the allergy from the nasopharynx or from the oropharynx, leading to mucosal edema of the eustachian tube, causing its blockade and resulting in decreased ventilation of the middle ear, causing development of negative pressure in the middle ear, and then resulting in retraction of the tympanic membrane. And also the bacteria, they reach the middle ear mucosa through the eustachian tube and results in mucosal inflammation and edema, goblet cell hyperplasia, and which leads to increased mucoid secretions. And then there is again superimposition of bacterial contamination of these secretions, leading to a flare up of the acute inflammation as profuse discharge, which eventually bursts out of the tympanic membrane, causing a perforation, that is a bout of acute suppurative otitis media. And then if there is subsequent incomplete treatment or improper treatment, then there is residual infection in the middle ear cleft, which again flares up after patient suffers from a upper respiratory tract infection or respiratory tract infection, again continuing the same vicious cycle of eustachian tube dysfunction and the following inflammatory process.
Well, that's a very elaborate thing, but I would like you to know there are three important functions of eustachian tube. What are they? Three important functions of eustachian tube.
So maintaining the ventilation
and pressure equalization. Okay. Not only the ventilation, you should always say ventilation and the pressure equalization. And you will also say clearance of middle ear secretions.
Clearance of the secretions of the middle.
And protection from the nasopharyngeal sound, pressure, and pathogens. So these are the three important functions of eustachian tube. So what are the three important dysfunctions of eustachian tube? What are the eustachian tube diseases you know?
Sir, chronic eustachian tube dysfunction leading to pars tensor retractions.
Very simple it is. One is eustachian tube blockade. The other one is eustachian tube widely open, patchless eustachian tube.
Patchless eustachian tube.
Yeah, and or a blocked eustachian tube. Now, the eustachian tube function is the most important success predictor for your laryngoplasty. So now tell us, how will you assess the eustachian tube function in a perforated ear?
Yes, sir.
If the ear is perforated, how do you assess the eustachian tube? Can you just tell us how do you use a tympanometry to do the eustachian tube dysfunction in a perforated ear? It's a very simple tool, but it will help us.
Yes, sir. Tympanometry we can do in a perforated ear by placing a aluminium foil in that around the area of that perforation, and we can record the pure tone audiometry and also the impedance audiometry. The tympanometry.
It does not do this. See, let's say that if you have a perforation in the middle ear, and if eustachian tube is blocked, okay. So what will happen is you will have a large volume of the middle ear, but actually peak will be achieved. The peak will be achieved little negative, but the middle ear volume will be very large. But if the eustachian tube is completely open in a perforated ear, you will not be able to achieve any peak. That's where you might get a flat curve. You may not achieve any peak. So these are the two ways with which you can do an impedance audiometry to see the eustachian tube function. So if the eustachian tube is blocked, and we do a tympanoblastry, what are the precautions that you will take? Let us say that the eustachian tube is blocked. You found that eustachian tube is blocked, and you want to do a laryngoplasty. What will happen if the eustachian tube is blocked? If you do a laryngoplasty, again there will be retraction, and again there will be perforation. How will you how will you go ahead with this? How will you prevent this? One simple way is you put a cartilage tympanoplasty. You do a cartilage tympanoplasty, or otherwise you clear the eustachian tube blockage. Simply just irrigate the eustachian tube blockage with saline when you do the surgery, or you do a eustachian tube dilatation procedures with a balloon. So these are the small things that you do for eustachian tube. I don't want to ask you a lot of questions, but I thought I'll tell you these things because eustachian tube is the most important success predictor. As a postgraduate, this is where you'll find difficult when examiner asks what is the eustachian tube function and what is the, I told them there are three eustachian tube functions. One is pressure and ventilation equalization, drainage of the secretions, and prevention of the nasopharyngeal pressure and prevention of the nasopharyngeal pathogens to enter. And how will you assess the eustachian tube function in a perforated ear? You do an impedance audiometry. Impedance audiometry usually will not be advised in a perforated ear, but if it's perforation, let us say that it is perforated and tympanic membrane is perforated and the eustachian tube is not blocked. So you will never achieve a peak. That's where you will get a flat curve. If eustachian tube is blocked, you will get a negative peak, but you will have a large middle ear volume. Volume will be little more than the usual middle ear volume. So when you see eustachian tube blockade, you need to remove the eustachian tube blockade before you do the tympanoplasty. Either you do a cartilage tympanoplasty or you do a complete irrigation. Okay, complete irrigation of the eustachian tube before
eustachian tube.
You just do irrigate. And there are some questions are there in the chat box. Do you want to address them? Dr. S.B.
Yes, sir.
Pulkar has asked, yes. So, Dr. Pulkan, you want to ask the questions yourself, or shall I discuss the questions?
Abhinav, can you?
Pukan sir has asked a question that is importance of the mucosal folds in the mucoid variety of COM. To enjoy. That's an you have presented nicely. Now, Fukan sir has asked you what is the importance of the mucosal fold in the mucoid variety of COM.
So, if permitted, I will help enjoy. So, what
Yes.
importantly we need to do is in a middle ear disease, when we do a tympanoplasty, when you set the definition of tympanoplasty very nicely, you need to eradicate the disease. You find some granulations and you want to eradicate. The most important thing that you will do is to check the patency of the aditus. So, how do you check the patency of aditus? You have to do a inspection antrostomy. You have to open the mastoid and then you have to do an inspection antrostomy. If there is blockage of the aditus, you will have to clear the disease from the aditus and establish the patency. So now this is a simple, not a simple, this is a very important procedure that we do in most of the cases of tympanoplasty. So this is governed by your mucosal folds. Mucosal folds, they compartmentalize the middle ear and they can obstruct the tympanic isthmus and these granulations, the pathological thickening, the edema, the scarring of these folds can obstruct the tympanic isthmus, can obstruct the ventilation routes, leading to poor aeration and negative pressure. So we need to be very sure that we establish the ventilation pathway from the aditus. And also the eustachian tube. Okay, so this is the most important role in the of the mucoid CSOM. We need to be very sure that the ventilation pathways are established. Okay, so the next question sir has asked is chronic otitis media and chronic suppurative otitis media. Can anyone tell the difference? Or Dr. Anjay, you want to tell the difference?
Chronic otitis media is a recent term which is being used in place of chronic suppurative otitis media, as it has been seen that otitis media, which is this chronic variety of otitis media, is not always associated with suppurative disease. There may be disease or granulations, unhealthy granulations associated with non-suppuration also. So that is why this terminology of chronic otitis media is more commonly used nowadays in case of chronic suppurative otitis media, which suppuration is generally which is seen in the tubotympanic disease.
Yeah, very good. One is, as you told very rightly, chronic otitis media is a broader term. It includes other diseases like necrotizing otitis media or even your chronic
This is related activity.
adhesive, especially the adhesive otitis media. Chronic suppurative otitis media is the inflammation of the mucoperiosteal lining with suppuration. So that is the major difference. You need to be very small in answering your answers. The examiners are always like one-line answers. Okay. So,
Yes.
sir is also asking, what is toss and SAID staging of TM additions? Will you be able to tell, Dr. Anjay?
Yes, sir. The TOS classification is for the pars flaccida classification, uh, and which is classified as TOS 1 is there is mild atic retraction, where and the pars flaccida has not touched the neck of the malleus. Then grade 2 will be the pars flaccida lies over the neck of the malleus. It touches the malleus. Then grade 3 will be uh, grade 3 was there was mild attic erosion. Attic erosion has begun and it is mild. And grade 4 was there is substantial attic erosion. And say this classification is for the pars tensa classification. Grade 1 in which grade 1 retraction is tympanic membrane pars tensa touches over the handle of the manubrium of the malleus, and grade 2 was the tympanic membrane retracts further and it reaches the lies over the long process of the incus, and in grade 3 class retraction of pars tensa, their tympanic membrane wraps around the promontory. It lies over the promontory. However, it is mobile. That means on Valsalva maneuver or sigillization, the tympanic membrane lifts over the promontory. Then in grade 4 grade 4 retraction, the tympanic membrane is atelectatic to the promontory.
Yeah, that's very good. You described the stages. But what sir has asked is, what's the importance of this stage? Let us say that, let us say the importance of pars tensa retraction. If higher the grade, what does it indicate?
Sir, it indicates there is residual station tube dysfunction, which is causing this retraction grade of retraction to increase further. Also, there might be development of adhesions in the middle ear, which is pulling the tympanic membrane further inside the middle ear.
Yeah. So higher grades indicate severe relationship dysfunction, near complete loss of middle ear space. There is no middle ear space at all. Once it goes into grade 4, there is no middle ear space at all. And once stage 3 or stage 4 happens, there is loss of, there is a higher risk of ossicular damage, poor ventilation. And they support the decisions on ventilation tubes, tympanoplasty, type of tympanoplasty, and further surveillance. So that is the importance of this staging system. Okay, so now sir is also asking for cauterization, would you do phenol or trichloroacetic acid? So you presented what is the chemical cautery agent that you do in
Trichloroacetic acid is used with silver nitrate.
you use anything. So we definitely have come across all these things. We are not doing this cauterization anymore because there is lack of control of cauterization in material, especially with junior residents doing it. So what we do is we'll be very happy to take the patient inside the OT, and we do freshening of the margins under anesthesia, and we do a small spot graft. Many times we do this for small fat graft, so that if there is a tiny perforation, That is where your chemical cautery might work. And for a residual perforation, especially after a surgery, when you have a residual perforation, we used to do this silver nitrate thing on it, but now difficulty in getting all these things and getting the concentrations clear is not that easy. So now we have come out of all these things and we are doing only a fat. Even if it is a residual thing, we just put a small fat crab that will help. Dr. Anja, you want to answer the next question? Role of mastoid buffer effect.
Sir, the extent of mastoid pneumatization also plays a role in the in the chronic suppurative otitis media pathogenesis of this disease. So the more is the pneumatization of the mastoid, the better is the ventilation of the medullary cleft. So the a sclerotic mastoid will be having maybe having a severe disease as compared to a pneumatic mastoid.
Very good. Especially in eustachian tube, when the pressure changes are not allowed by eustachian tube, a large mastoid volume dilutes any small pressure changes. Okay? So patient may be doing well with respect to ventilation, but not with drainage. So that is the magnitude buffer. Sir, Dr. Pulkan, you want to explain a little bit anything about more about mastoid buffer effect?
Concern.
Okay, fine. So that's fine. So you want to add?
Hello.
Fukan
No,
sir,
I don't want that. Hello.
Yes, sir, you're audible, sir.
Oh, actually, I will not aid, but you explained nicely. But actually, it has got a role like a station function. That as you mentioned, your tympanometry, how it helps, like that of the master buffer effect, also is a great role in hearing improvement in laryngoplasty or in complication of mastoiditis. That's my thinking. You can add.
Okay, yes, sir.
Yes, sir. A well pneumatized mastoid will have a better tympanoplasty or a myringoplasty outcome than a sclerotic one.
Yes, sir. And the last question by sir, any molecular studies in COM? Now, this is always a googly. When examiner asks molecular studies, we are very much into surgical field, and even I am not able to answer this molecular study in COM. But sir, you want to answer this question yourself, sir?
No, this is something mentioned in Scott Brown 8th edition. It's a purely research product, actually. As he has mentioned about the interleukin and the
Interleukin
eosinophilic
1B.
one is other things. But there is many research I found in some literature. But I think all are like that. In cholesterol also, there is some marker like that in your unsafe variety. Like that, here also it is same thing.
Yes. So you need to know a little bit genes. I think recent edition Scott Brown has given about examples. And the best thing about this, no, you take any gene until it will be agreed, because many of us do not know about unless otherwise you are well read like Pulkan sir, you cannot sometimes get away with sir. But I think sir has asked a very relevant question, and I think one more question I missed.
Yes.
How
Sir, one question.
How sensorineural hearing loss occurs in COI? What's the mechanism of sensorineural hearing?
It is caused due to the bacterial toxins reaching the inner ear, the hair cells of the cochlea, and also due to the immune mediators, the inflammatory cytokines, and also the interferons like interferon 6, interferon 8, which mediates tissue destruction in the inner ear.
Yeah. So what happens is not only the toxins that are going, the permeability of the round window increases.
Round window increases.
permeability increases. Like, when the permeability increases, all these toxins, because it's exposed to chronically these inflammatory toxins and the bacterial toxins, all these will cause sensory hearing loss. There is a chance. Yes, I think it was a very good presentation, and I don't want to take much time. Sir told only 10 minutes for me, but I have exceeded a little more time. I think for the interest and benefit
No,
of
sir, you
discussion.
are well. You are welcome, always welcome, sir. If you want to add anything, please.
No, ma'am. I think
Any
eustachian tube
recent.
eustachian tube dysfunction and eustachian tube functions are the must for any postgraduate, especially in tubotympanic disease. And there will be a question on eustachian tube dysfunction. What are the differences in adult and pediatric eustachian tube, and how eustachian tube contributes to the disease management? So that's what I wanted to add specifically in tubotympanic disease, because this is where when we go into station tube, the students get really worried. So there's nothing to worry. There are only a few questions. If you answer these questions, they will let you go. Okay, no, nothing more. They want you to test. Yeah, fine. Anything else anyone wants to discuss?
So there is another question has come up. What are the red flag symptoms in CSOM that must never be missed in OPD to prevent complication?
Yes. Dr. Sharma sir has asked.
No, Dr. Nivaran Sharma.
Oh, Dr.
Yes, sir.
Nivaran.
Nivaran
Yeah,
Sharma.
Nivaran.
Yes.
Yeah.
Yes, sir. Red flag signs include, sir, development of dizziness or vertigo in a patient of CSOM, which may suggest impending intracranial extension of the infection. Then any history of blurring of vision, neck pain, or any rise in temperature, sudden rise in temperature. Then in cases of infants, any new development of lethargy or refusal to feed or inconsolable cry. These are generally the red flag symptoms which may point us towards development of complications or new onset of development of intractable headache.
Yeah, I think you have straight away gone into articular disease. Okay. So even in patients with tubotympanic disease, we have got some complications like tinnitus. As you said, increased permeability of the toxins and inflammatory mediators will cause tinnitus, will cause sensory hearing loss. So this patient will actually present with tinnitus, vertigo. Any patient with what to say, tubotympanic disease presents with tinnitus, vertigo, you should be very, very sure that you rule out this labyrinthitis, because you miss this labyrinthitis, you will think that something else has happened. And as you rightly said, yes, new onset fever, new onset headache, and neck stiffness, facial weakness. Even the other important thing is the CSOM tubotympanic disease will have a concurrent Bell's palsy. So that is where we'll be a little worried. Is this Bell's palsy, or is it complicated thing? You go into CT scan and all. Usually in a patient with tubotympanic disease, the classical teaching is there is no need for a CT scan. You just do an X-ray mastoid and then proceed with that. And your pupil audiometry will tell you how much hearing loss is there. And based on the hearing loss, you can predict whether the auritus is functioning, whether if the hearing loss is more than 40 or 50, and the hearing loss is mixed, you always look for the auritus blockade. Okay, so that is where there's a clue that will help us to, and especially when there's an ossicular erosion. Intraoperatively, ossicular erosion is there. And obviously, PT will show a higher hearing loss and a mixed hearing loss. All these should be picked up prior. These are the things with respect to tuberculosis disease. Okay. Otherwise, the decision making, whether you go for tuberculosis disease, whether you do a simple meninoplasty, or you will go for mastoid exploration. Depends on all these factors. Okay, apart from that, the red flag symptoms that you told will do very well. Yes. Yeah, there's one more question. What's the time frame to declare chronic versus acute otitis media? What's the time frame?
It is 6 weeks.
Yeah, different books say different things, but 6 weeks, some examiners will even want 3 months or 6 months.
3 months.
So this is the classical duration, but some duration also comes with your definition of, the prerequisites for laryngoplasty. The prerequisites, classical prerequisites for laryngoplasty is the ear should be dry for at least
Dry.
6 weeks. Some people say 6 weeks, some faculty say 3 months, some faculty
3
will say
months.
6 months. So that differs from their own practice and their own understanding. So likewise, the duration also differs from textbooks, from disease to see in a dry place like Pondicherry. The dryness for just 6 weeks is even okay for us to do a laryngoplasty. But I've heard from the place which is cold, they just want the ear to be dry for more than 6 weeks. They don't accept the definition of 6 weeks for the ear being dry. So these are all small things that we need to mix and match with the examiner's mind reading. Okay. Yeah.
Thank you,
Okay.
Doctor. Thank you very much, Dr. Shivaraman.
Okay.
May I
Okay,
ask
sir.
Dr.
Thank you,
Abhinava
teacher.
give you some comments on it?
Yeah, I think so. Anjay has done a good job uh, showing the slides about the conductive, the chronic otitis media. Just to finally uh, summarize everything, I think so. Sir has also taken up the questions brilliantly and given the answers so that all the PGs and all the consultants can be um, greatly benefited, because this is a very uh, basic bread and butter of us ENTs. And just one final question is that why does bony resorption occur in tubotympanic disease? Hello.
Yes, sir. There is, due to repeated infection of the middle ear mucosa, the inflammation reaches beneath the mucosal layer into the submucosa, in the submucosal tissues, reaching the periosteum of the bone, and thus there is beginning of osteitis in tubotympanic disease.
Actually, what happens is when you have a retracted tympanic membrane, or even like a perforation, when you have a retracted tympanic membrane wrapped upon the ossicles, there is upregulation of the inflammatory cytokines, and also the osteoclasts, which cause the
Bone resorption.
slow resorption of bone, and also a tightly wrapped tympanic membrane or mucosal band over the ossicle can cause uh, blockage of the capillaries. So that also contributes to the bone resorption. Yeah, I think so. Everything has been covered in
Thank you, sir.
this topic, and sir has also summarized everything very nicely. So I think so, ma'am, we can close.
We can close it with a vote of thanks. Okay?
Yes.
Okay, this is my
Thank
part.
you, teachers, for
Thank
giving
you.
this opportunity to me.
Okay. On behalf of the Scientific Committee of Nebaoi, I sincerely propose the vote of thanks for today's academic session. We express our heartfelt gratitude to our esteemed expert, Professor Shivaraman sir, for his insightful expert comments and valuable guidance. Our sincere appreciation goes to speaker, Dr. Anjay Kumar Pal, for an excellent and informative presentation. We also thank our moderator, Dr. Abhinava Ghosh, for conducting the session and enriching the discussion. Special thanks to our President, Dr. Shubhamoy Chakraborty, Honorary Secretary, Dr. Anjan Bhuya, and Scientific Committee for their efforts in organizing the academic program. Finally, we thank all participants for their active involvement. With this, I conclude today's Nebaoi Classroom. Thank you all.
Thank you very much.
Thank you, teacher.
Professor Shivaraman, thank you very much. Anjan is a very nice presentation.
Yeah,
Right.
Anjay, you have